Hi, and welcome back to Ready, Set, GYO, your on-the-go guide to learning gynecologic oncology. I'm Sydney.
And I'm Maya. This is a podcast for fellows by fellows. We are here to help you explore the diagnosis and treatment of gynecologic cancers, master the standards of care, and stay on top of new practice-changing publications.
Let's get ready to GYO.
In this episode, we're going to be discussing postoperative complications and emergencies, including the diagnosis and management. This episode will be a foundational one for residents, APPs, as well as fellows. Sydney, what are our learning objectives for today?
Our learning objectives are to provide a structure for thinking about postoperative complications, either with or without a fever, and to explore the diagnosis and management of common or serious postoperative complications and emergencies, including MI, acute respiratory failure, hypovolemic shock or postoperative hemorrhage, DVT and PE, necrotizing soft tissue infections, fascial dehiscence, vaginal cuff dehiscence, bowel obstruction, anastomotic leak, bowel perforation, and pancreatic leak or fistula.
Great. We're going to structure this episode thinking about the 5 causes of postoperative fever that we all learned in residency: wind, water, walking, wound, and wonder drugs. For this episode, we'll expand the 5 Ws to include surgical and postoperative complications in addition to fever, and we'll review several complications or emergencies that can fall under each of these categories. These categories traditionally describe causes of fever, but they can be helpful as a framework for evaluating or thinking about postoperative complications in general. We're going to add to this mnemonic with a 6th W of waves to describe myocardial infarction, which is the most common cause of serious morbidity or mortality on post-op day 0. At the end of the episode, we'll review some complications that don't quite fit into that structure, so stick with us. As with many of our episodes, we'll put some helpful figures that go along with the episode on our website. The most common causes of postoperative complications include superficial surgical site infection, pneumonia, UTI, deep organ space surgical site infection, kidney injury or failure, MI, and VTE. The timing of presentation can be helpful for your differential diagnosis. In the first 48 hours, non-infectious causes should be top of mind, while after 48 hours, infectious causes rise in incidence. Immediate postoperative fever is common, and when present in the first 24 hours is often benign. After evaluating the patient, if there are no concerning findings, observation and routine postoperative care is recommended, as these fevers typically resolve spontaneously. So Sydney, can you start walking us through our 6 Ws?
Yes. We'll start with the W that we're adding, waves. As we mentioned, this is the most common serious post-op complication on post-op day 0. 8% of patients undergoing non-cardiac surgery show evidence of myocardial injury, and 2% suffer significant morbidity or mortality due to perioperative cardiovascular complications. Postoperative patients with MI have a different presentation than what we normally think of. Dyspnea is the most common complaint, and due to postoperative analgesia, they often lack the classic chest pain or pressure. EKG findings in postoperative MI are also not classic. Typically, they will show a non-Q wave variant. Serial troponins are still highly specific. Remember to keep this on your differential. Postoperative stress may be higher than your patient's normal ambulatory activity. These events occur due to a supply or demand mismatch in the myocardium, so it's crucial to correct hypotension, anemia, and arrhythmias. Maya, how can we help reduce this risk of this complication?
If patients take a beta blocker as part of their medication, continuing this throughout the perioperative period decreases the patient's risk of MI. That's not the case for starting a new beta blocker, however. If you start a new beta blocker within 1 day of surgery, there's actually an increased risk of death overall, even though MI events are decreased. Otherwise, be cognizant of those supply-demand mismatch risks that we talked about. The next W is wind. Postoperative pulmonary complications occur in 1 to 3% of gynecologic surgeries. The most frequent and serious postoperative complications include pneumonia, acute respiratory distress syndrome, known as ARDS, obstructive sleep apnea exacerbations, and acute respiratory failure, which can be precipitated by any of the above. Atelectasis is another phenomenon that can occur, but isn't a true complication or emergency, and the evidence linking atelectasis to fever is inconsistent. Sydney, can you tell us about acute respiratory failure?
Absolutely. There are two major types of acute respiratory failure. Type 1 occurs due to inadequate exchange of oxygen and can be precipitated by atelectasis, pneumonia, PE, or ARDS. It's characterized by a low partial pressure of oxygen, less than 60 millimeters of mercury, with a normal or decreased partial pressure of carbon dioxide, aka hypoxia without hypercapnia. Patients will have a normal or increased alveolar arterial AA gradient. Over time, if the condition worsens or becomes chronic, type 2 acute respiratory failure involving both hypoxia and hypercapnia will develop. This involves the inadequate exchange of carbon dioxide, is defined by an increased arterial carbon dioxide greater than 45 millimeters of mercury, decreased arterial oxygen less than 60, and a low pH less than 7.35. This occurs as a result of conditions that cause pump failure or increased CO2 production. Pump failure is much more common. Sometimes these are classified as can't breathe etiologies, like muscle or chest wall fatigue, narrow airway, restrictive defects, or won't breathe etiologies, like central respiratory drive issues or anesthesia overdose. As always, start an evaluation with a good exam. With atelectasis, you may hear diminished breath sounds, have dullness to percussion, and see poor oxygenation. Remember to use incentive spirometry to prevent this. With pneumonia, expect a fever, purulent secretions, vocally diminished breath sounds, and/or cough or dyspnea. Other physical exam findings for respiratory complications may include crackles at the lung bases if there's fluid overload, among others. Labs may be nonspecific. Get an ABG, CBC, and consider coags. With pneumonia, expect a leukocytosis. With ARDS, labs are variable, but coag factors, as well as labs for end organ damage or signs of shock, are important. Imaging is key for the diagnosis. Linear densities in the lower lung fields suggest atelectasis, newer progressive infiltrates suggest pneumonia, and bilateral opacity suggests ARDS. Remember your ABCs: airway, breathing, circulation. Treatment is aimed at identifying the underlying cause and correcting it. While trying to find the cause, provide support with supplemental O2 or mechanical ventilation as necessary. Eventual resolution of all causes of respiratory failure is treatment of the etiology. Maya, can you tell us a little bit more about a couple specific etiologies of acute respiratory failure?
Yes. Let's start with ARDS. ARDS is an acute, diffuse, inflammatory lung injury, which leads to increased permeability of the alveolar capillary barrier and non-cardiogenic pulmonary edema. It's always a reaction to some insult, which causes increased production of cytokines, leukotrienes, endothelial molecules, and interleukins. While other organs may also be affected and fail due to this inflammatory release, the lung is often the first organ to go. To diagnose ARDS, patients must have impaired oxygenation and meet these three criteria. First, onset within 1 week of a defined insult. Second, X-ray with diffuse bilateral infiltrates. And third, respiratory failure, which cannot be fully explained by fluid overload or cardiac failure. The severity of ARDS can be assessed using the Berlin criteria. There are calculators online, which uses a combination of the PO2, FiO2, and required PEEP. There's a VQ mismatch in ARDS due to alveolar damage, which leads to a hypercapnic state and respiratory acidosis. If using mechanical ventilation, improved survival has been seen using low tidal volumes with permissive hypercapnia. Pneumonia can also lead to acute respiratory failure. When diagnosing and treating pneumonia, it's crucial to distinguish between community-acquired pneumonia and hospital-acquired pneumonia, including ventilator-associated pneumonia. Hospital-acquired pneumonia describes pneumonia which is diagnosed more than 48 hours into an admission, with no signs at the time of the admission. Treatment should involve your hospital antibiogram, as patterns of antibiotic resistance differ regionally. Generally, it's appropriate to begin with broad-spectrum antibiotics and to tailor as appropriate. Asthma and COPD exacerbations can also lead to ARDS. Prevent and treat asthma exacerbations with scheduled albuterol or nebulizers, and make sure people's home regimens are available. Patients with COPD can generally be managed with non-invasive ventilation like high-flow oxygen, CPAP, or BiPAP. The management of COPD includes schedulizing nebulizers, steroids, and antibiotics. As always, consult your specialists if needed to optimize care. We've mentioned mechanical ventilation a couple of times. How do we know or decide when patients may need mechanical ventilation?
Good question. While some of this may seem out of the scope of gynecologic oncologists, as many modern ICUs have a closed system, these topics are important for recognition and initial decision making while patients are on the floor, and to keep us as active participants in the care of our patients while in the ICU. Mechanical ventilation addresses oxygenation and ventilation, and we need to consider both of these aspects when deciding which patient needs mechanical ventilation. From an oxygenation perspective, we should aim to be able to keep the O2 saturation above 90 to 92% with supplemental oxygen and to keep the PO2 greater than 65 millimeters of mercury. From a ventilation perspective, tachypnea with a respiratory rate greater than 35 per minute or a PCO2 greater than 55 are general indications for intubation. Other indications include apnea or respiratory arrest, altered consciousness level impairing normal respiration, hemodynamic instability. We're not going to discuss ventilator management in this episode, but each of our textbooks have great chapters on critical care. We encourage you to read more there.
Let's move on to our second W, water. Both the intraoperative period and postoperative period present risks of complications in this category. We'll talk about the postoperative period today. Ureteral injury and bladder injury is a risk in gynecologic surgery due to anatomic proximity of these structures to our operative field. Ideally, these are identified intraoperatively, and their management is discussed in our other episode about intraoperative complications. However, if a ureteral injury is not identified intraoperatively, postoperative signs and symptoms include abdominal and flank pain, fever, leukocytosis, and an elevated BUN level. Patients may have a postoperative ileus. Labs should include a fluid and serum creatinine. An elevated fluid creatinine coming from the abdominal cavity is very suspicious for ureteral or bladder injury. If the serum creatinine does not rise more than 0.3 mg per deciliter, there is a 98% sensitivity and negative predictive value of 100% in confirming bilateral ureteral patency. Imaging, including a pyelogram, CT, or MRI, can help identify these lesions. If an injury is identified postoperatively, it can be tricky to manage, and you should involve your urology colleagues. If there's no surrounding inflammation and the ureter was cleanly transected or sealed and is not spilling urine, you can consider immediate repair. Otherwise, it's recommended to wait at least 6 to 8 weeks for re-exploration and repair due to inflammation. Percutaneous nephrostomy tubes can be placed as a temporizing measure. Urinary fistula diagnosis and management is similarly not straightforward. Management depends on the structures involved, the size, and the timing of development. The abnormal connections are pretty self-explanatory. Vesicovaginal describes bladder to vagina, ureterovaginal describes ureter to vagina, urethrovaginal describes urethra to vagina, etc. Vesicovaginal fistula are the most common after gynecologic surgery. As a group, these can occur due to gynecologic surgeries, colorectal or urologic procedures, radiation therapy, prolonged catheterization, or trauma during surgery, as well as ischemia of tissue due to excessive cautery or suturing. Do you remember the tampon test from Creogs? Classically, you can give a patient pyridium to dye the urine orange and instill methylene blue into the bladder. The patient inserts a tampon, and if the tampon is blue, it suggests a vesicovaginal fistula, and if orange, a ureterovaginal fistula. Alternatively, perform a CT urography, retrograde pyelography, or MRI to localize the lesion. For select cases of small, early vesicovaginal fistula, conservative management with a Foley catheter may spontaneously heal it. If very small, on the order of millimeters, silver nitrate may help. Otherwise, if needing definitive surgical treatment, this should be delayed 3 to 6 months until the fistulous tract is matured and inflammation has resolved. Interposition grafts, such as a Marsh's flap, may be used to support the repair. If there's a small ureterovaginal fistula, a stent can be placed to see if it spontaneously heals. Otherwise, the patient will need a percutaneous nephrostomy tube and a reimplantation at a later time. Sydney, let's switch gears and talk about another complication we're putting in the water category: hypovolemic shock and hemorrhage.
Let's do it. There are variable definitions of intraoperative hemorrhage, but typically this is defined as greater than 1 liter of blood loss or blood loss requiring transfusion. Severe postoperative anemia, less than 7, impacts perioperative morbidity and mortality. For now, we're going to talk about management of post-op, not intra-op hemorrhage. Recognizing the problem promptly is key. Patients may have abdominal pain or rigidity, rebound or guarding, anxiety, and diaphoresis. Orthostatic hypotension is typically the first sign, which will progress to generalized hypotension and decrease pulse pressure due to vasoconstriction. Late signs are altered mental status, marked tachycardia, syncope, oliguria, and AKI. In younger patients, BP is typically maintained longer in the setting of a hemorrhage because autonomic nervous system tone can maintain normal BP until cardiovascular collapse is imminent. Initial management should be IV fluid replacement with LR, blood products as needed, and identifying the source of the bleed. If hemodynamically stable, CT scans, often with angiography, is the imaging study of choice. While if hemodynamically unstable, a fast scan or a diagnostic peritoneal lavage can be done, although I can't say I've ever seen a DPL. If a bleed is identified and the patient is stable, assess whether IR embolization could be employed versus transfusion and watchful waiting for the bleed to stabilize. If unstable or if these measures fail, return to the OR as needed for definitive management. Maya, walking is our next W. Can you walk us through the diagnosis and management of DVT and PE in postoperative patients?
Absolutely. In gynecologic oncology, our patients are at a higher risk for thromboembolism due to a hypercoagulable state of malignancy. Ovarian cancer patients have the highest risk of VTE due to large tumor volume and prothrombotic cytokines in acidic fluid. Clear cell carcinomas, including ovarian and endometrial clear cell, have an even higher risk of VTE, possibly due to higher tissue factor production. In fact, in a study published by Deska et al. In 2010, 42% of patients with ovarian clear cell carcinomas experienced VTE throughout their treatment course. Perioperative rates of VTE in gyn-onc surgery are up to 26%, and the rate of PE after gyn-onc surgery is up to 9%. Preoperatively, risk assessment can help triage which patients require mechanical or chemical VTE prophylaxis. The Caprini score has been validated in many surgical populations. This is an online calculator that helps decide how to risk reduce for VTE. The Caprini score does not stratify or modify for MIS surgery, so it might overestimate the risk of VTE in our patients who undergo MIS. Postoperatively, for patients with cancer getting open surgery, 28 days of prophylactic anticoagulation is recommended to reduce the risk of VTE. For patients that have MIS, unless they have other risk factors, it's safe to stop anticoagulation upon discharge. When working up postoperative patients for potential VTE, remember that a D-dimer will not be reliable and should not be used, as it will be elevated in the postoperative state. Pulmonary embolism can be life-threatening, and prompt diagnosis is necessary. Patients most frequently have sinus tachycardia without other signs. They can also have a mild fever, nonspecific chest X-ray findings, and can potentially show signs of right heart strain on EKG with larger PEs. Formal diagnosis depends on the stability of the patient. If you suspect a patient may have a PE and they're unstable, so they have hypotension, evidence of shock, then it's reasonable to start empiric anticoagulation and provide targeted resuscitation. And you can do this without or before you've completed imaging if the patient is unstable. Resuscitation would include vasopressor support, fluids, oxygen, with potential need for mechanical ventilation. Thrombolytic therapy in a postoperative patient can be dangerous, and so typically anticoagulation is done first. If there's a concern for bleeding risk, an expedited workup should be done so alternative therapies can be considered. If patients are stable, then Wells criteria can be used to assess the pre-test probability of a PE, and that can guide decisions on imaging. CT angiogram is the most commonly used test to confirm a PE. After diagnosis, therapeutic anticoagulation should be employed. Low molecular weight heparin has less risk of thromboembolism and has less major bleeding risk than IV unfractionated heparin, and is the best choice in stable postoperative patients. After initial treatment, transitioning to a direct oral anticoagulant, or a DOAC, is safe and has equivalent outcomes to heparin products, unless there are contraindications. Duration of therapy is at least 3 months, but depending on the patient's cancer course and treatment, that duration may change. Sydney, for our next W of wound, we're going to talk about infections, sepsis, and other wound complications. Can you start us off?
Of course. To narrow our discussion of wound infections, I'm going to focus on diagnosis and management of necrotizing soft tissue infection, a true emergency. Concerning physical exam findings for this would include dishwasher gray drainage from the wound, crepitus in the skin around the wound, and rapid progression of illness. If you do an exam and you find these signs, the next steps are to start broad spectrum antibiotics and head straight to the OR for wound debridement. This is not the time to order and wait for a CT scan. Mortality from necrotizing soft tissue infections increases with time to debridement. You should get labs and wound cultures, but again, don't wait for the results to start treatment. If you're taking a patient for debridement, consider giving tetanus prophylaxis. Surgical infections classically present on postoperative day 5 to 7. When evaluating these patients, it's important to triage which patients are very sick or have sepsis. Sepsis describes life-threatening organ dysfunction caused by a dysregulated host response to infection. Our gynecologic oncology patients often have several risk factors for sepsis and the presence of infection, so it's important to identify these and treat. Risk factors include cancer, immunosuppression, age greater than or equal to 65, diabetes, and obesity, among others. We talked about febrile neutropenia in our chemotherapy emergencies episode, so refer back there for that discussion. The definitions of sepsis have changed a lot in the last couple of decades. Currently, the most commonly used tools to triage patients and assign a severity of illness related to sepsis are the Q-SOFA, standing for Quick Sequential Organ Failure Assessment Score, and the NEWS calculator, National Early Warning Score. These are both available online and can help triage what level of care will be appropriate. The key to managing suspected sepsis is early antibiotics, ideally within 30 minutes of presentation and certainly within 1 hour. Make sure to grab 2 sets of blood cultures prior to starting antibiotics, including one from any indwelling lines like a Metaport. Start broad-spectrum antibiotics using your hospital antibiogram. Then, try to identify the source of the infection so treatment can be tailored. Maya, what about other wound complications?
The other wound-related complications we want to discuss are dehiscence of various sorts. We'll start talking about abdominal wound dehiscence, which can be superficial, including the skin and subcutaneous tissues with intact fascia, or deep with fascial dehiscence. While in both cases, there can be erythema, induration, and drainage from the wound, the presence of copious fluid 5 to 7 days out from surgery is worrisome for fascial dehiscence. In some cases of fascial dehiscence, the skin may actually be intact and still approximated. It's crucial to open the skin and probe the fascia to evaluate. This is another case where management is immediate surgical intervention, not requiring imaging. At the bedside, a sterile, moist dressing can be placed over the open wound to protect the bowel. Management includes debridement and reapproximation. The STITCH trial, a multi-center, double-blinded RCT published in 2015 in The Lancet, showed small bite fascial closure to be superior to large bite fascial closure, with rates of midline laparotomy incisional hernia at 1 year of 13 versus 21%. Specifically, the incision was closed 5 millimeters from the fascial edge, and each stitch was placed 5 millimeters apart in the small bites group versus 1 centimeter by 1 centimeter in the large bites group. While this study wasn't specifically looking at rates of dehiscence, this is something to incorporate to improve the quality of our fascial closures. Vaginal cuff dehiscence is another surgical emergency, diagnosed with a good physical exam. If you see bowel in the vagina, you can use a surgical marker to mark the area that has eviscerated, so that when you run the bowel intraoperatively, the area at risk will be easy to identify. Originally, when robotic surgery was just being introduced, there was a higher rate of vaginal cuff dehiscence in robotic compared to laparoscopic surgery, but this has improved. It's thought that contributing factors were decreased size and quality of bites on the vaginal cuff when suturing robotically. However, this hasn't been proven definitively. The last W is wonder drugs, or wonder about drugs, or what did we do, which covers iatrogenic sources of postoperative fever. Remember that these complications can occur at any time, and the evaluation is based on the presenting signs. Okay, Sydney, that covers all of the W's, but we have a couple more postoperative complications that we want to cover in this episode. Can you tell us about some complications related to the GI system?
Of course. We wanted to talk about bowel obstruction, diagnosis, and management. Specifically, we wanted to talk about how to differentiate between a complete and partial bowel obstruction, as well as a postoperative ileus, which will be on the differential diagnosis. Patients with an SBO may still have some passage of flatus and stool from contents of the bowel distal to the obstruction. On physical exam, patients with an ileus will have hypoactive bowel sounds. After a laparoscopic surgery, these usually resolve within 3 days, but may last 5 days after an open surgery, especially with bowel surgery. Patients with a bowel obstruction may have high-pitched bowel sounds on exam, as well as tachycardia and oliguria, sometimes with fever. An abdominal x-ray can be helpful in the initial evaluation of these conditions. With an ileus, there should be uniform gaseous distension of both the large and small bowel. With an SBO, there will be distended loops of small bowel and air fluid levels with a paucity or complete lack of gas in the colon. If you see an enlarged cecum on x-ray, this should raise concern for a large bowel obstruction and requires further evaluation by barium enema or colonoscopy. A CT scan with oral and IV contrast with small bowel follow-through is very helpful for distinguishing between an ileus, partial, and complete SBO. Gastrografin administration can actually aid in resolution of small bowel edema due to a high osmotic gradient, so it may improve symptoms. If a partial SBO or an ileus is diagnosed, conservative management is the first-line therapy with electrolyte and IV fluid repletion, antiemetics, a nasogastric tube, limitation of opioids and other medication which reduce bowel motility, and early ambulation. Remember to always administer a PPI or other prophylaxis for acid reduction to prevent stress-related mucosal damage. 90% of postoperative SBO, if partial, will resolve with conservative management. Complete bowel obstructions, either from the small or large bowel, are another story. These often will not resolve spontaneously and require surgery. Closed-loop bowel obstructions are a surgical emergency where a segment of intestine is obstructed at 2 points, forming a closed loop with no outlet either proximally or distally. This can rapidly lead to bowel ischemia, necrosis, and perforation due to the trapped gas and secretions causing increased pressure. Large bowel obstruction is a rare postoperative complication but can occur for other reasons. If the cecum is greater than 10 to 12 centimeters on imaging, surgery is urgently needed due to an elevated risk of perforation. Maya, if we've performed bowel surgery, when should we be concerned about an anastomotic leak, and how are these managed?
Anastomotic leak occurs after 2 to 7% of bowel anastomoses. The lowest risk is with an ileocolic anastomosis of 1 to 3%, and the highest risk is with a coloanal anastomosis, 10 to 20%. Risk factors for anastomotic leak include emergency surgery, prolonged operative time more than 4 hours, contamination of the peritoneum, hypoalbuminemia less than 3, smoking or alcohol excess, obesity, immunosuppression, including from diabetes or cancer, ASA class 3 to 4, a history of radiation, and a distance from the anal verge of less than 6 centimeters. In 2017, there was a prospective study published in Gyn-Onc, which presented an algorithm for preoperative triage of patients potentially getting bowel anastomosis. Patients were categorized as low or high risk based on several of the above risk factors, in addition to performance of a leak test of the anastomosis. If patients were deemed to be high risk, they received a temporary diversion. This accounted for 35% of patients. Among diverted patients, there were no anastomotic leaks. Overall in the study, the anastomotic leak rate using this triage system was 1.3% versus 8% in a historic cohort from the same institution. Short-term outcomes were not different between diverted and non-diverted patients. 89% of patients initially diverted were successfully reversed. Other strategies, like placing pelvic drains at the time of anastomotic surgery, have not turned out to be helpful in preventing leaks, and drains are not recommended routinely for this indication. In a review published in Gynonc in 2012, preemptive drain placement did not improve postoperative outcomes. However, some advocate for placement of an intraperitoneal drain near the anastomotic site for early detection of leak. Anastomotic leaks typically present 5 to 7 days postoperatively, but in 10% of cases, they might not present until after 30 days. Once diagnosed, the initial management includes NPO status, broad-spectrum antibiotic coverage, and IV fluids. Definitive management depends on the size and severity of the leak, using abscess size as a metric. If there's a small abscess of less than 3 centimeters, it's reasonable to manage with bowel rest and antibiotic administration. If larger than 3 centimeters, consider percutaneous drainage, bowel rest, and antibiotics. If there's a major defect involving more than 1/3 of the circumference of the anastomosis, an abscess which can't be drained, gross spillage, a free intraperitoneal leak, or clinical deterioration, then more aggressive management is necessary. Options include an XLAP with creation of an end colostomy, resection of the anastomosis with reanastomosis and proximal diversion, or if the defect is minor and the tissue quality is good, rarely you can consider primary repair of the anastomosis with drain placement and proximal diversion. Endoluminal vacuum therapy is another technique which isn't widely used in the US, but has good success rates in the management of small defects in stable patients. Sydney, how does diagnosis and management differ for bowel injury or perforation compared to the anastomotic leaks mentioned above?
So it's possible that bowel perforation presentation may be similar to the presentation of an anastomotic leak, but this varies. Symptoms can include abdominal or chest pain. Sudden, severe abdominal or chest pain after surgery is concerning for perforation, but remember to think about the other differential diagnoses like MI or hemorrhage. Pain may radiate to the shoulder if the diaphragm is irritated. If the perforation is in the retroperitoneum, symptoms may be more subtle. If there is a free perforation, the patient will often be able to pinpoint the exact time when the symptoms started. Patients may present initially with a sepsis picture, with an abdominal mass, or could present with a fistula as a late complication or presentation. Physical exam will initially show focal tenderness or potentially be normal, eventually with distension. Vital signs vary depending on how sick the patient is, but can include tachycardia or hypothermia. Again, these initially may be normal. Labs are also nonspecific, with an elevated white cell count, elevated lactate or CRP, and eventually elevated amylase. Imaging with gas outside the GI tract is characteristic. An abdominal series, including supine abdominal, upright abdominal, and chest x-ray views, is often performed first, but a CT will be better at localizing the perforation, especially when given with PO and/or rectal contrast. After laparoscopic surgery, this can be tricky, as there may be some postoperative air in the abdomen. Management is very similar to the management of anastomotic leak and depends on the severity of the presentation. IV fluids, NPO status, broad-spectrum antibiotics, and include an IV PPI if upper GI perforation is expected. As with anastomotic leak, you can consider conservative management. Indications for an XLAP include abdominal sepsis, worsening or continuing pain, diffuse peritonitis, and signs of bowel ischemia. Maya, can you walk us through our last complication, pancreatic leak?
Yes, this last complication is probably something new from residency. The risk of pancreatic leak usually occurs during a distal pancreatectomy, which occurs inadvertently during splenectomy. Injury to the pancreas has been reported in up to 22% of splenectomies. These leaks can lead to pancreatitis and pancreatic fistula, which occurs in 1.5% of splenectomies. Pancreatic fistula presents with left upper quadrant pain, fever, and leukocytosis. The diagnosis is aided by ultrasound and/or CT scan and is confirmed by image-guided percutaneous fluid sampling to check for amylase-rich fluid. When performing this test, cultures should also be obtained to rule out an abscess. Drain amylase is a useful test, but there isn't a complete consensus on exactly which definition to use. In a Cochrane review published in 2017, they emphasize that different studies have used different timing of collection as well as different value cutoffs. Cutoffs used in the Cochrane review studies included 3 times the level of the serum amylase, which had a 41 to 75% post-test probability of a positive leak, a value greater than 600 units per liter that had a 38% positive predictive value, or a level of 4,000 units per liter with a 95% positive predictive value. Sometimes they were measured on day 3 or sometimes on day 5 after surgery. The conclusion from the Cochrane review was that a drain fluid amylase of the 5th postoperative day, using a threshold of 3 times the serum amylase, provided the best sensitivity with high specificity. A negative test more or less rules out a pancreatic leak, but a positive test is less certain. Patients with a pancreatic leak will be asymptomatic if the leak is grade A. This is usually a transient occurrence and does not require treatment. With grade B leaks, patients are symptomatic as above. They may have leukocytosis and abdominal pain and do require treatment. If your amylase level is concerning for a leak, especially if there are symptoms, then a CT abdomen pelvis should be performed to evaluate for the fluid collection, which should then be drained if present. Conservative treatment of the pancreatic fistula is ongoing drainage, close monitoring for signs of sepsis, and can sometimes require NPO status with enteral or parenteral feeding. That's all we have for you today. We hope you learned something on today's episode of Ready, Set, GYO, a podcast for Gyn-Onc Fellows. Here are your key takeaways from today's episode.
The 5 W's, which have traditionally been used to describe causes of postoperative fever, can also be employed as a framework to evaluate non-febrile postoperative complications. Wind, water, walking, wound, and wonder drugs are the classic 5. A 6th W, waves, includes the consideration of myocardial infarction, which is the most common cause of morbidity and mortality on post-op day 0.
Some postoperative phenomena are relatively benign or self-limited, such as superficial surgical site infections, ileus, and UTI. Others, such as MI, severe acute respiratory failure, fascial dehiscence, necrotizing soft tissue infections, and closed-loop bowel obstructions are true emergencies. There are other complications, such as anastomotic leaks and bowel perforations, in which management is more nuanced and ranges from conservative management to urgent surgical exploration, depending on a variety of clinical factors. This has been another episode of Ready, Set, GYO, your source for all things Gyn-Onc.
If you'd like to check out today's show notes, take some practice questions, or explore resources we use to create the podcast, head to readysetgyo.com, the companion website for our podcast. We encourage you to reach out if you have ideas for new episodes, questions or comments about existing episodes, or thoughts of how we can make this podcast even better suited for you. We're excited to continue to learn with you.
To stay up to date on all things Ready, Set, GYO, check out our Instagram and Twitter at Ready, Set, GYO.
To support us and our production of future episodes, check out our Patreon at Ready, Set, GYO.
This episode was recorded by Sydney Oesch and Maya Gross. Our sound editors are Brogan Brown and Kylie Knight. Our media and website manager is Sky Jacobson.
We'd like to thank Dr. Justin Harold, faculty at the Medical University of South Carolina, who reviewed the content of this episode for accuracy and completeness. Sydney and Maya, signing off.